Hi, I'm Dr. David Ilson from Memorial Sloan Kettering Cancer Center. Today I'm here with Dr. Axel Grothe from the Mayo Clinic, and we're here to review best of the day from ASCO in gastrointestinal cancers. On the docket today are discussions of new therapies in colorectal cancer, and I thought of particular relevance was some of the data for the new immunologic therapies in colon cancer.
You know, I think every tumor entity wants immune checkpoint inhibitors to work. And the data so far in unselected patients in GI malignancy, in particular colorectal cancer, had not been very encouraging. And yesterday morning, and at the same time with a publication in the Journal of Medicine, we actually have the first data set for patients with colorectal cancer showing quite dramatic responses to a PD-1 antibody, pembrolizumab. So just to highlight what happened was MSI high tumors, which constitute about 15% of stage 2, 8% of stage 3, but only 4 to 5% of stage 4 patients, they have hypermutated tumors. They have a lot of antigens that are potentially recognizable by the immune system. And we've known for a long time that we see lymphocytic infiltration in these tumors, in primary tumors, for instance. So there has already been some idea about the immune system could potentially recognize these tumors. We just need to give the immune system a kick. And that will happen in this study led by Johns Hopkins investigators, looking at MSI high versus MSS colon cancer, but also MSI high other cancers like endometrial cancer, biliary cancer, and gastric cancers. And they found that in a last line setting, the patients who received with MSI high tumors had a 62% response rate when single agent pembrolizumab was used. Now, admittedly, it was only 13 patients, but the spaghetti plots, the kind of how patients responded, was quite impressive. A separation clearly between MSS tumors, no response at all, MSI high tumors, the majority of patients had response, and some of them lasted almost durable, long-term durable response for more than a year.
Yeah, many investigators were almost ready to give up on immunotherapies in colon cancer. But I think this was hypothesis-driven that the MSI high tumors have a higher neoantigen burden and potentially are going to stimulate an immune response better. And I think it's obviously going to lead to further study as well as potentially earlier line study of these agents in colorectal cancer.
Absolutely. So this opened the door. I think when we talk about biomarker, and even if we only talk about 4 to 5% of patients with colorectal cancer, that's a significant number of patients around the world. And I think we're facing exactly what's happening in other tumors. We're 2% here, 3% there. We're developing targeted therapies for subset of patients.
Yeah, I think we're also seeing interest in these agents now in esophagogastric cancers. Very promising data, phase 2 data for pembrolizumab in esophagogastric adenocarcinomas, not only in patients in Asia, but also in the rest of the world. And the trial that Dr. Bang updated looked at patients that had biomarker selection for PD-L1 overexpression, which is the ligand that activates the PD-1 receptor. And in that population where they allowed positivity for PD-L1 either in the tumor cells or the stroma, they identified about 40% of patients that were candidates and reported a pretty impressive 20% response rate, encouraging median overall survival. Some of the responses were quite durable. So I think there is going to be interest in moving these drugs forward potentially in biomarker-selected patients. I think still there will be an interest because the data is still very preliminary to look also at unselected patients to make sure that we're not missing a signal. But these agents are going to now move forward in first-line treatment, potentially in combination with chemotherapy, second-line versus second-line chemotherapy, and there's a lot of excitement now also in esophagogastric cancer about moving these drugs forward, given the signal.
Immunotherapy, unfortunately, has made it into GI malignancies, and I think the durable response is really what drives my interest. Now, when we talk about kind of selecting patients, biomarker selecting patients. Another interesting theme here at ASCO, oh my God, at ASCO was BRAF mutant tumors. So BRAF mutant colon cancers make up about 8% of metastatic colon cancers. And we've known these patients need better therapies than we have because they have poor prognosis, they're relatively refractory, especially to second, third line therapies. And there's a target that apparently drives tumor biology. So we've seen here at ASCO actually two interesting studies using complete biologic agent, a BRAF and a MEK and an EGF receptor inhibitor, panitumumab. Another study with a BRAF inhibitor plus an EGF receptor antibody and irinotecan, so good old chemotherapy. And both showed actually quite interesting response rates in the range between 26-35%. I don't think there's a clear winner which one of these trials has the better activity, but we also face some side effects of the treatments, in particular when you combine an EGF receptor antibody and a RAS MEK inhibitor, RAF-MEK inhibitor, skin toxicities, which are not trivial and led to dose reductions in a lot of patients.
Yeah, it's very interesting that that the use of BRAF inhibitor drugs alone in colon cancer was a complete failure, but there appear to be these feedback loops that may act through the EGF receptor, so that combining a BRAF inhibitor with an EGFR inhibitor may lead to potentiation of activity, and now even adding other inhibitors in the pathway may lead to further benefits. But it's clear that just in many cancers, just identifying the mutation and giving one drug is not the answer.
Yeah. And the interesting thing was they actually did interesting phosphor-ERK studies, expression levels. So if we talk about the RAS-RAF signaling cascade ends up with phosphorylated ERK, you give vemurafenib alone in melanoma, you can almost completely shut down phosphor-ERK. But even if you give trametinib plus vibrafenib in colon cancer, you still have not shut down phosphor-ERK completely. So there seems to be some other redundant mechanisms of activation of this pathway, which are tumor entity dependent, melanoma different than colon cancer.
Yeah, and I think in terms of looking at some of the new targeted therapies in esophagogastric cancer, we saw positive and negative results. I think we saw in very encouraging randomized phase 2 data for VEGF targeted therapy, looking at regorafenib versus best supportive care in late-line therapy in esophagogastric cancer. We saw improvements in progression-free and overall survival, indicating that this class of drugs does have activity. Very similar sort of hazard ratio outcomes if we look at drugs like ramucirumab, perhaps in an earlier setting. So I think there is a potential for regorafenib to be studied in later line treatment. And I think reviving the interest in VEGF-targeted agents that ramucirumab has stimulated, that we now have active drugs that may be potentially studied in this disease after earlier disappointing results from first-line use of bevacizumab.
Yeah. So one thing actually that in gastric cancer, since you talked about this, was one of the highlights was you made David Cunningham concede that anthracyclines are not necessarily needed based on his own trial.
Yeah, I think the OE05 trial is one of the practice-changing trials that was presented at this meeting. This was a 900-patient study of esophageal and GE junction adenocarcinomas, where in Europe the standard of care is often to give perioperative chemotherapy, and without radiation, which is a debatable point, but their practice pattern is chemotherapy alone. And they had an earlier trial of preoperative chemotherapy, just giving 2 cycles of 5-FU cisplatin versus the more magic approach, which is perioperative ECF. So this was a head-to-head comparison of the 2 cycles of 5-FU cisplatin versus 4 cycles of preoperative ECF, ECX using capecitabine. And at the end of the day, there was no survival difference, which to me is a stunning result, because it really argues that more cycles of chemotherapy doesn't make a difference, that there was no difference in survival, and also the anthracycline did not add a benefit. So yes, when I asked Dr. Cunningham, what should be the regimen endorsed now in these patients, he said that anthracyclines really should not be used. They probably don't add any benefit. Also, if we look at data from the gastric realm, where there's pre- and post-operative chemotherapy, there are similar outcomes for platinum 5-FU with or without an anthracycline. So I think this is practice changing. If we really take that drug out of the mix, it's likely to lessen toxicity. And certainly for the esophagus and GE junction tumors, less chemotherapy, perhaps 2 cycles, may be enough. Dr. Cunningham also made the point for esophagus and GE junction tumors there was a very low rate of R0 resection. Even in endoscopic ultrasound PET scan staged patients, it was only about 60% per treatment arm. If we look at the data for chemoradiation from the Dutch cross trial, R0 resection was 92%. So Dr. Cunningham admitted that perhaps for the esophagus and GE junction tumors, combined chemoradiation may be the better strategy, and that for the gastric cancers, chemotherapy alone may be acceptable.
Yeah. So coming back to, we're bouncing tumors around, which is great. Colon cancer was not that interesting this year. I thought, we saw the PD-1 data, which we already talked about, the BRAF data. There was something about liver-directed therapy, the so-called Sears flux data.
Yeah, I think the liver-directed therapy was a theme from the oral presentations.
Exactly.
What was your take on these studies?
So the idea was, what does liver-directed therapy with radioactive spheres in early line therapy contribute to outcome? Because I think a lot of us use these radioactive beads, radioembolization, in later lines of therapy to turn things around, to treat patients with liver-dominant disease. But we see a response, but we never knew exactly what happened in terms of, does this really confer an overall survival benefit? Now, in this first-line trial, adding these Sears spheres, radioactive beads to FOLFOX, there was no difference in progression-free survival overall. So it's a negative study for its primary endpoint. Now, having said that, the study included 40% of patients with extrahepatic disease, which did contribute to the progression events. And when you now just looked at the liver-limited disease, liver-limited progression, there was an effect. Actually, I think not unexpected. Now, the question is, how would that ever influence our standard of care? Or would that influence our standard of care? And I don't think it does. I think we're still using these tools, in patients with liver-dominant or liver-exclusive disease. I think they could work, but that we don't have data saying, if we do this, we have a clear survival or progression-free survival benefit.
And we really need to wait for overall survival, and there are several studies where they're going to pool the results, and because actual progression-free survival overall was not better, although liver progression was better.
Selecting patients, I think, is the critical issue for those. Then they had an update of the CLOG study, a Dutch study, where they looked at the kind of radiofrequency embolization, to kind of free the liver from liver metastasis as much as possible. And we have seen the data before. They have actually been presented several times. There's a overall survival trend for an overall survival benefit, I guess, in an underpowered study overall. I think, again, it wouldn't change our standard of care. What it does highlight, we have tools to render patients free of disease, to attack liver-limited disease, and in select patients, I think they can benefit from these tools.
Yeah, I think before moving on to a discussion of neuroendocrine tumors, I also just wanted to comment just on the last negative trial, which was for rilotumumab in gastric cancer. Adding a MET-targeted drug did not improve survival despite a very strong signal from the phase 2 trial. So very disappointing negative results in a immunohistochemistry selected population that had MET overexpression. So a pretty significant negative study. What was your take on the role of bevacizumab in the trials that were done in neuroendocrine tumors?
So one trial compared, in carcinoid tumors, bevacizumab to PEG interferon, pegylated interferon, which is not necessarily the standard of care. We don't know, we have no contemporary data that really shows how active or if this drug's active at all. It was clear the side effect profile of the two different arms were different. I mean, we know that interferon induces fatigue, and some hematologic toxicity. Bevacizumab induces hypertension. I mean, so that was quite consistent with expectations. No difference in primary outcome. So really a wash. So you can say both agents are equally effective or non-effective. There was a higher response rate if you look at it for bevacizumab, but if it doesn't translate into gains in survival in this very indolent malignancy, I think it's hard to gauge any, let's say, place for a role for bevacizumab. The other study was adding bevacizumab to everolimus, which is an mTOR inhibitor, which has been approved
in the pancreatic neuroendocrine tumors, more responsive tumors.
Yeah. Well responsive, better responsive to chemotherapy. They respond to chemotherapy, and the study was statistically positive for its primary endpoint with a different p-value cutoff of below 0.15. so positive for PFS with a hazard ratio of 0.8. More responses with bevacizumab, again, in these indolent tumors. I don't know what response really.
He also has a much higher adverse event rate. It was almost
adverse
double.
event rate,
A lot of it was hypertension and proteinuria, but and how to interpret a higher response rate when there were marginal differences in progression-free and overall survival in an indolent malignancy, difficult to interpret. But
it's difficult to run good trials in these malignancies.
But certainly the response rate for 2 biologics was very encouraging because it seemed to be better than everolimus alone. And how that's going to be taken further, we'll have to see.
So pancreas, what's new in pancreas?
Yeah, pancreatic cancer, I think there were some interesting presentations. I think the adjuvant trial from Germany, CONCO-5, they were the first group to identify gemcitabine as a positive adjuvant drug. So they now looked at a randomized trial only in R0 resection patients at gemcitabine plus erlotinib for 6 months, based on the metastatic disease data. And the primary endpoint was disease-free survival, and they saw no difference. So that the trial did not meet the primary endpoint. It's not likely that erlotinib adds a benefit. There was a little bit of a puzzling late survival benefit for erlotinib, but the survival curves didn't separate until 3 or 4 years.
I don't think that's real.
So to me, that indicates an effect more of later therapy than what was done earlier. So I think this, in conjunction with the LAPO-7 trial, which also showed that adding erlotinib to chemoradiation added no benefit, and that even radiation added no benefit, but adding erlotinib actually was detrimental in the LAPO-7 studies. So I would say that the use of erlotinib will never move forward in the adjuvant setting.
And the intergroup trial, or the R2G trial, actually kicked erlotinib out of the...
Yeah, erlotinib was one of the arms, the systemic arms, and now it's gemcitabine alone versus potentially allowing other adjuvant treatments like gemcitabine Abraxane, so that trial is still accruing. And very interesting data for this hyaluronidase drug combined with gemcitabine Abraxane. We know that pancreatic tumors have a lot of stromal issues, and that the dense sort of fibrous stroma may prevent drug delivery. So the hypothesis was that giving hyaluronidase with the chemotherapy might enhance drug delivery. So this randomized phase 2 trial, and they had a biomarker selection for patients that had both high and low levels of hyaluronic acid in their tumor biopsies. Patients that were hyaluronic acid high when they got the drug plus Abraxane had higher response, progression-free, and trends towards overall survival benefits. So I think now our plans to take this to a phase 3 in the biomarker-enriched population, which would be the hyaluronic acid high, which is about 50-60% of the patients.
It's quite substantial. So I actually like this abstract quite a bit because, I have a good rationale, you have a biomarker selection, it makes sense, we know part of the problems we have in pancreas cancer is drug delivery. It's a very fibrotic tumor, and some of these cells are covered with this HA, so I think it's a very interesting approach. We need phase 3 data.
Yeah, there was an issue of thromboembolic events with this drug, but when they incorporated the use of prophylactic low molecular weight heparin, there was no difference in the treatment arm. So it may make therapy a little more cumbersome with the requirement for anticoagulation, but some in the past have made arguments for whether or not this should be used in pancreatic cancer management routinely. But certainly in the context of this trial, that will be part of the therapy regimen.
I think we covered it all. No, I don't think there's any earth-shattering data in HCC that I...
Yeah, again, to me, the real practice-changing trial that came out of the esophagogastric sessions was OE05, which showed that we got the same outcome in survival for 2 cycles of 5-FU cisplatin versus 4 treatments with ECX. Essentially indicating longer therapy was not better, and that the epirubicin and the anthracycline didn't add benefit, and it probably should be taken out of the mix.
Yeah. And for me, my takeaway in my colorectal cancer field is we have a biomarker for immune checkpoint inhibitors, MSI high tumors, New England Journal publication at the same time point of the presentation. I can actually see that we'll dive into the MSI high tumor, hypermutated tumors. There are hypermutated tumors beyond just the MSI high tumors, polymerase mutations, for instance. that we will see a lot of trial activity, a lot of actually patient requests even coming back for drugs approved in different indications. Now you come back after ASCO and patients have an MSI-high stage 4 tumor in a last line setting and they say, doctor, I just saw this presentation of this publication, why don't I get this PD-1 antibody?
Yeah, actually, just to comment on one other interesting molecular subset, the last presentation yesterday looked at HER2 positive colon cancer, which they identified it was about 4 to 5% of patients. So this was a very ambitious trial in Italy. These were patients refractory to all treatment.
5 lines.
And they identified about 5% that were actually HER2 positive. Because they were so ill, only half of the patients ultimately got treated. But they saw about a 25-30% response to a combination of trastuzumab and lapatinib in HER2 positive colon cancer late line. And some of these responses lasted beyond 6 months. So I think the study of these molecular subsets may be useful, that we may identify a biomarker-driven treatment that may help patients even in late-line therapy, but very provocative data.
So I have a slide actually created last year, but my top 3 targets for colon cancer was BRAF mutation, MSI-high tumors, and HER2 overexpressors. And when you add them up, you're still below 20%. And that is where we are right now. The rest, we need to dive into the 80% of patients we don't have anything.
Yeah, and there's actually some evidence that when you develop resistance to EGFR inhibitor drugs, that HER2 may be amplified. So you may actually need to test it later on, in a later biopsy, because it may emerge later as a mechanism of resistance to EGFR therapy.
Sounds good. So I think we covered it all. David, it was nice chatting with you. You introduce, I'll close out. It was fun. And next year at ASCO, we'll be back here again. Thanks for watching.
Thanks very much.